Well, welcome to today's video. Thank you for tuning back in. Now, I've got some interesting data from the Office for National Statistics and the Oxford Centre vaccine study today, looking at antibody levels. So this is quite reliable data we have to look at today, and it's going to be focusing on the UK mostly, but it will have great implications for all other countries because it's starting to tell us something, or quite a few things really, that are fairly fundamental about the nature of this disease and how it interacts with people. So let's kick off with some data as we normally do, because what we normally say is how many cases there have been. So the official number of recorded cases in the UK is 293,000 officially diagnosed cases. But the Office for National Statistics indicates that the real number could be 2.8 million. And the COVID symptom tracker app indicates it could be higher than that. But I'm going to give evidence that suggests it could be 5.6 million. And this isn't too far away really, because we have thought for some time that maybe up to 10% of the UK's population could now be infected. And what is true of the UK is probably true of quite a few other countries that have had a similar recent 6 months to the UK, shall we say. Now, the deaths in the UK are recorded now to include hospitals, care homes, community, everywhere. And this is based on fairly accurate data now. So the deaths in the UK that are attributable to COVID-19, this is people dying from COVID-19, not people dying with COVID-19, as we looked at yesterday, is just over 55,000. Now, this is an interesting thought exercise, but it's a bit more than that really. So if we take the official number of cases here as being 293,000 from testing, with 55,000 deaths, that would give us a case fatality rate or a case fatality ratio of 19%. So 19%, that's 19% of that number there. If that was the official number of, if the official number of diagnosed, tested cases indicated the real number of infections. But if the actual number of infections are 2.8 million, then for 55,000 deaths, that will give us a case fatality rate of 1.9%. That'll be 1.9% approximately. And if the real number, as I suspect, is 5.6 million, or in that area, that's going to give us a case fatality rate of 0.98%. So in other words, this idea that there's a 1% infection fatality rate, that 1% of the people that actually are infected die from this condition, based on UK data, then that would indicate that 1% is probably fairly accurate. So 0.98% from my calculations, the 1% infection fatality rate that we've been thinking about for some time, looking like, for westernised countries at least, that's not too far out of the way. Now, developing countries have a younger population, but they have more malnutrition and comorbidities. So we need more data to adjudicate how much that applies to poorer countries. But for Western countries with a similar demographic to the UK, that 1% is not too far out. Now, the next calculations are speculative, of course, but we do know that about 70% of people will need to become infected to have herd immunity and stop the transmission of this virus. So that gives rise to some possible concerning calculations. Now, 70% of 326 million, which of course is the population of the United States, 70% of that is 228 million people. And you don't need to be a mathematician to work out that 1% of that is well over 2 million. So it looks like unmitigated if the infections are not controlled. It's not ludicrous to suggest that the death rates are potentially of this order in the United States. Now, I know what you're thinking, because I'm thinking it as well. This is unimaginable. This is unthinkable. But there again, where we are now was unthinkable in January. So I think this just shows, this reinforces time and time again how important it is to stop the spread of this virus. Because these are the sort of numbers that we are potentially talking about. Now, if my mathematics here is well, I think the simple maths, I might have made a mistake, but it's these kind of numbers. Do check it by all means. But if I'm making some fundamental mistake in epidemiology here, I'm afraid I don't quite see what it is. So these are the risks that we're talking about. Population of the UK, 66 million, 70% of that to get herd immunity, 46 million, and 1% of that is just under 500,000. Now, even the official government scientists were saying that it could be 190,000 would potentially die this winter if this pandemic is not curtailed and the curve is not flattened. So if official figures are basically 200,000 could die from that, then that means these calculations aren't too far out, unfortunately, because this virus is going to carry on spreading until 70% of people have immunity. Now, from my somewhat speculative figures, but to me rational figures, or rational risks, shall we say, rational dangers, let's go on to the Office for National Statistics, which is compiled by, unlike me, proper, very clever statisticians. England and Wales, week ending 3rd of July 2020. This is week 27 of the year. Now, of course, these figures are always behind because there's a lag in collecting the statistics and processing them. And this is a community-based survey, not hospital or care homes. So this is community-based survey, people at home. Come up with some interesting figures. And this is the first one. Deaths involved with COVID-19. This is in this week ending the 3rd of July. In that week, there was 532 deaths attributable to COVID-19. And that's 5.8% of all the deaths in that week. So in that week, 532 deaths attributable to COVID-19. Down, of course, massively on where we were a few months ago. So still not flat, still there, still 532 deaths a week, but down a lot on where we were. Now, 8th of July. This is the 8th of July. What they actually did was they took a week and they said in the middle of that week, this is what the number was likely to be. So it's likely, it's close anyway, that on the 8th of July, there was 24,000 people who were currently infected in the UK on the 8th of July. 24,000 infections. And that's based on antigen testing data. Now, they didn't test 24,000 people to get that information. They extrapolated up to the whole population. But from the antigen testing data that was available to the Office for National Statistics, they estimated that on the 8th of July, 24,000 people had active infection in the UK. Now, again, this is massively down. This is in one sense, very, very good news. It's way down on what it was. But it still means that the infection is still present in the community, remember, and there is still ongoing community transmission. And as we saw yesterday, this means if you take the brakes off, that could accelerate. The virus is still there, and it's still there in reasonably substantial numbers of infections. Even although that only works out at 1 in 2,300 of the population. But that's enough to reignite the fire, to reignite the chain of infection. given that the actual people that have been infected and therefore probably have a degree of immunity in the UK is still less than 10%. Now, the ONS estimated there was 1,700 new cases of COVID-19 per day in that week. And remember, that's the week ending the but this is the week ending the 3rd of July. In that week, the estimated 1,700 new cases of COVID-19 per day. New cases per day. Now it's hopefully a little lower than that, but that was equivalent to 1 in every 5,000 people in the UK. So 1,700 new infections per day at that time. Modelling shows evidence that the decrease in COVID-19 rates has levelled off. So we know that these figures are much lower than they have been, which of course is great news. They're much lower than they have been. But the rate of decline has now levelled off, and it seems to be kind of level. So the number of new, in other words, the R0 can't be too far from 1 now, because the number of new infections is roughly equivalent to the number of people recovering or some dying, unfortunately. Now, more interesting data here. COVID-19 infection survey up to the 8th of July, based on blood samples. So 4,309 blood samples received since the start of the study on the 26th of April. And this indicates that 1 in 16 people, 6.3%, who provided blood samples up to the 8th of July tested positive for antibodies. So these are the antibody tests now. So this is saying, according to this data, 6.3% of the population have probably had COVID-19 based on antibody data. So that's probably the best figure we've got from the 8th of July. 6.3% of people have had the infection. But actually, if anything, this is going to be an underestimate, and we'll see why this is going to be an underestimate later. That equates to 2 million people in England. So that was where I got that first figure from. That's where I got that figure from. 2.8 million people. That's the ONS figure, based on antibody studies. It's an extrapolation, but it's based on good quality antibody studies. So 2.8 million people in England have probably been infected already. Now, just before we leave the Office for National Statistics, face coverings when outside the home. They have figures on that. And this is based on data for the 8th to the 12th of July. Now, 61% reported wearing a face covering when leaving the home in the past 7 days, up to 52% from the week before. But to be fair, this is people that reported going out of the home into a public area wearing a face covering at least once in the week. So it's not as good as the figures look. So, but anyway, it had gone up. It had gone from 52% to 61%. So more people were wearing face coverings between the 8th and the 12th of July. 10% had used a pub or a restaurant, 9% had used a hairdresser, which was extra data they have. Now, let's just look at that in some graphics related to that. Now, what they've done here is actually separated the figures for England and the figures for Wales, but we see they have a fairly similar pattern. So March in England, great increases in April, then May, June, the death rate going down, which is reassuring, and a similar pattern in Wales. So deaths involving COVID-19 in blue, deaths due to COVID-19 in yellow. Now, there were more deaths involving COVID-19 amongst males than females, and here we have the age distribution. So thankfully, very few deaths in younger people, but then the deaths increases with increasing age. And we see that men are dying more than women, apart from the very oldest group where there's more women dying than men, but this is because more men have already died by that age demographic. So as we've seen many times, the increase in deaths with increasing ages. Here's the data for wearing face masks. Now, given that wearing face masks is mandated in Scotland, I must say that this is pretty disappointing. So less than 80% of people in shops wearing face masks when it's mandated. That should be 100%. But of course, they're doing way better than England. In England, it's not going to be mandated till the 24th of July. You work out why that delay is there. I have no idea. Wales was even lower. More women wearing face masks than men. That's interesting. But here we see people aged over 70 and over are more likely to wear face masks for the amount of protection it will give them, as people with various comorbidities like health conditions and things like that. So we see that the motivation for mask wearing there is partly to protect the individual. But we really need this up to be 100% after the 24th of July. And why we're waiting for then in England, I have no idea. But Scotland's better, but given it's mandated. Oh, now this is interesting. Of course, we've long talked about the variation in death rates in various ethnic groups. Now, this green line here is the one to look at. These are households that contain someone aged between 0 and 19, 20 to 69 and aged over 70. So we see there's more tri-generational households amongst Bangladeshi, Pakistani and Indian people, and indeed black African derivative peoples as well. So I thought that was quite interesting. So this could be partly accounting for the increased incidence in Pakistani and Bangladeshi people. Although, of course, as well as increased incidence, these ethnic groups have more complications. So it could be that they've had a higher exposure dose as well as a result of living in more people living in generational households. That's quite possible. Now, moving on to information from the Oxford vaccine group now. Oxford vaccine group, coronavirus immunity in children. They are studying, so that's interesting. So you can read that there for yourself. Now, this is the Oxford vaccine group in collaboration with Public Health England, in collaboration with the National Institute for Health Research. So this is kind of proper research people in the UK, so it should be good data. 750 families in the trial. They went around taking blood from children who nobly volunteered. So fair good sample size there, 750 families. And of course, the Oxford vaccine group know how to pick representative samples. There's no question about that. So they're looking at the prevalence of COVID-19 in children, checking for coronavirus antibodies. So checking for the presence of the antibodies. And they found that 3 to 4% of children tested positive for antibodies. Now, as we'll see, the real number of children that have been infected could well be twice this. And the group admit this is an underestimate. And I'll tell you later on why I think it might be twice that. It's due to studies in Sweden, actually. So 3 to 4% of children tested positive for antibodies. The proportion was higher in London, where there has been more infection. So that kind of makes sense. Now, 10% of those who tested positive, fewer than 10% showed any symptoms of COVID-19. So this is interesting. This means that children, of all the children that tested positive, that have definitely had exposure to coronavirus, COVID-19, 90% of those children were asymptomatic. And this included young teenagers as well. So children and younger teenagers, 90% getting completely asymptomatic disease. Only 10% showed any symptoms. Small amount. Now, therefore, children have similar infection rates to adults, but a higher proportion are asymptomatic, is what the study concluded. So children are just as likely to get infected, but less likely to develop symptoms. And that's something we've been saying for quite a long time, actually, on this channel. So that's consistent. Very few children and teenagers are experiencing symptoms. 2 reasons for this suggested. One is they have less ACE2 receptors, which are where the virus latches onto the cells of the body. And the other is there could be cross-immunity with other recent coronaviruses. Now, this isn't actually put forward by the Oxford group, but I've got this from other data, and I think it's quite possible. So what we know is that there's different types of coronavirus. There's 4 types of coronavirus cause mild common cold type symptoms. So it could be that children have been more exposed to these common cold type coronavirus symptoms, developed antibodies to that form of coronavirus, And the common cold type coronavirus antibodies are giving some level of protection against the COVID-19 antibodies. It's what we call cross immunity. So that could be happening. But the team go on to say something interesting here. Children are very good at spreading the influenza virus, which we know. So classically, children get the influenza virus at school and take it home to their parents. But the team say the children are not so good at spreading COVID-19. Now, the brief report that they gave from this reference doesn't give us enough information to work out why they're saying that. But nevertheless, that's what these researchers are saying. So we have to accept it really on their word until the full papers are published. So children can spread influenza virus very readily, but they don't spread COVID-19 to parents as readily. Not saying they don't spread it, they still will do, but just less than influenza. Now, memory T cells. Now, just a brief report on this, and this is what ties in the Swedish data. Now, I'll just explain what happens here. What we have in the blood is we have lymphocytes, a type of white blood cell called a lymphocyte. And a type of lymphocyte will detect the particular virus, the antigen. And once it's detected it will make millions of copies of itself that can also recognize the antigen. And then these T cells will inform the B cells, another form of lymphocyte, that will actually make the antibodies. And then after a while, after about 50 days, the antibodies will leave the blood. They'll no longer be there, but the memory T cells will still be there. So a population of cells that remembers exactly how to make the antibody are left in the blood. And these are called the memory T cells. And then if the virus comes back, these memory T cells will divide up very quickly, a process called clonal expansion. And we'll have millions of them, billions of them maybe, I'm not sure, certainly tens of millions of them, before the person's had time to develop symptoms, I would hope. And that means that basically the memory T cells means that people will be immune. That's the hope. Because immunity is so much more complicated than just antibodies. So memory T cells, and studies have looked for these, may mean we have more immunity than antibodies indicate. That's why I said that 3 to 4% in children there could be an underestimate. And the real numbers could be double that. The real number of children that are immune could be double that. And that's based on work from Stockholm. Now, just before we do this, remember we got data from India that said the IgMs come first. They're the immediate antibodies, and the IgGs come later. But even the IgGs, the immunoglobulin type Gs, are only in the blood for about 50 days. But the memory T cells, we would hope, would persist. And studies in Stockholm, what it showed back in May was that 15% of people they studied had antibodies, but 30% had memory T cells. Now, the test for memory T cells is complicated because you're looking for a particular type of memory T cell that remembers how to make antibodies to the coronavirus. So it's a complicated test. I've never even seen it done myself, but I've seen lots of blood tests done in laboratories otherwise, but never that specific test. But they did that in Stockholm. We can do it in the UK. It's a bit tricky, but it needs to be done. So in Stockholm, 15% had antibodies, but double that amount had memory T cells. So, getting back to our original supposition here at the very start of this video, if you're still with us, the Office for National Statistics, this is based on testing here. But given that the real number of patients could be double, I know this was based on antigen testing, but the real number of patients could easily be double, which would give us that number there. And if that number there is correct, that gives us, as we've always expected, round about a 1% infection fatality rate. So just kind of putting those two bits of research together, that is a supposition I'm making. But that's based on research. Double the amount have immunity compared to the amount that have the antibodies. So, what this means is that immunity is more complicated to work out than just the antibodies. But we're still well under the amount of people that need to be infected to give herd immunity. So unfortunately, as we said yesterday, we are still near the start of this pandemic, unfortunately. Now let's look at some pictures just to finish off. Here we go. Now this is a shop in the United States selling masks, and it kind of amused me a bit because there's a mirror there for you to try them on. So just think about it. You try the mask on, you don't like it, you put it back on the shelf. I don't think you need me to spell that out any further. This is Karen and Izzy, who live in Lincolnshire. Good to see you watching in Lincolnshire. Oh, now this is Michelle in Austin, Texas. Now this is outside Michelle's shop, so let's just zoom in and look at that. So face coverings are required for all customers. That sounds pretty clear, doesn't it? Face coverings are required for all customers and associates per local state order. So masks and face covering at least have to be worn. So that's Michelle proudly showing that sign off correctly. But then when she went actually into the shop, she found that the police needed to be there to enforce this. Now this is just absurd. The fact that you need to put a full-time officer who could be usefully deployed doing lots of other things in a grocery store, which you can see there, is disappointing. And that's what the point Michelle was trying to get over, and I agree with her completely. People should be complying with this without the necessity for police enforcement, or only from the mildest correction from store staff if people weren't using it. So a bit of a disappointing reflection there, really. This is Ramon, who watches in Florida. Good to see you watching in Florida, Ramon. Thank you for watching. This is Rob, pictures taken by his wife Jackie, I believe, who watch in Wales. So good to know you're watching in Wales.